Good morning, everyone. You rest yesterday or you go to the party? Okay. It's a pleasure for me be here today and yesterday. This is the second time for me in Trinidad and Tobago. And finally, I could see the ocean. And the last time it was impossible. My challenge is give this presentation in 20 minutes. This is the innovative approaches to delivering PrEP self-testing and partner notification to key and vulnerable population. Like Carlota told us, the ideal prevention journey is not so ideal. When we start the prevention process when the test or with PrEP, we really believe that this person retaining the service and keep it HIV negative forever. Like when we marry it, we believe that we will happily forever, but this is not the life. Life is more complicated than it looks. We have problems, we have discussion, we have the sons, the school, when the kids are bad in the school, or some problems at the day. People have jobs, they can go to the appointment to the clinic, and they need to go other day, or that day the clinic is closed. They can make the refill, and they need to restart of their own. That means that we need to do the things differently because this is our reality. We have more than 500,000 people on PrEP, but according to the target, we need 2.5 million people on PrEP to achieve the elimination target. And you know, because you see the numbers yesterday, how many of these 167,255 are from the Caribbean. The majority of the people on PrEP comes from República Dominicana and Haiti. The other countries has small numbers of people on PrEP. That means there are many people we have not yet reached. And how do we close the gap of people accessing prevention service? WHO gave us this policy brief in 2022 talking about the differentiated approach for differentiated and simplified pre-exposure prophylaxis for HIV prevention. Since 2 years ago, talk about the simplify a differentiated approach, follow person-centered principles and community settings to promote the use of PrEP service that are demedicalized and comprehensive to make them more acceptable and accessible. Happening in each country, the PrEP is probably put in the service in a clinic with a doctor, with a physician, and a very well-structured, organized, but not so free of stigma, also open to the people that need it. And actually, we need to promote effective and consistent use of oral PrEP, maintain quality and safe service, and support the achievement of national, regional, and global goals. But what are the goals? Each country needs to put a goal. It's a question that you can keep it and analyze if your country have a goal. Because we need to support to achieve the goal, but we don't know really if we have a goal. For make all these things, we need to increase demand generation for existing service and increase PrEP options available to sexually active individuals. I hear all the time that WHO doesn't have recommendation for PrEP for cisgender women, and that is not true. Because WHO have recommendation for all the populations, MSMs, transgender women, cisgender women. We have a lot of options between the oral PrEP, on-demand PrEP, and now the cabotegravir long-acting injectable. But at the present, the researchers are doing more because they try to find some ways to give them to the people that they want. For example, oral pills to take for a week, vaginal ring that mix antiretrovirals and anticonceptives, like for 1 month, for 3 months, enemas, for tenofovir enemas that we saw in the HIV for prevention, and also different type of product like a subcutaneous injection, diaphragmas, implant. But all these are in different phases of development of the research. Recently, we see the result of the Purpose 1, of the Purpose 2, that give us lenacapavir, like prevention in long injectable action that we can see later. But innovative approaches is not only a new way to give the medicines. It's not only a diaphragma, a vaginal ring, or an injection. Innovative approaches include new ways to do the things for achieve the people. This is how to improve the implementation of testing and PrEP/PEP, because we need to think every PrEP program needs PEP. PEP is a tool that we have more than 1 decade before. It is not used enough in our countries. When we are using PrEP, we need to put PEP accessible for the people. That is one. The second is that we need to improve or accelerate the task sharing or task shifting to maximize the use of available human resources. But also we need to work in acceptability of provider type to PrEP users. PrEP users are not sick. They don't have HIV. Probably they have other diseases, I don't know, maybe have hypertension, diabetes, obesity, or flu, I don't know. But HIV they don't have, because the only requirement for receive PrEP is doesn't have HIV. And we need to be clear about this, because we need to make the service acceptable for people who doesn't have HIV. And we offer a strategy or an intervention for so many months, and probably the people has risked some of the time of the year, maybe 1 month, 2 months, of the partner comes 2 times a week, I don't know, 2 times a month. We need to talk with the people and really know what is the risk situation for adapt this intervention for this need. Also, we need to work in registration and regulation of provider type, because probably not everyone wants to talk with the physician about PrEP, of the sexual practice, of my sexuality, of all the things that you ask when it is necessary to use PrEP. And we need to work in training and accreditation for the lay providers. And also we need to think in remuneration for the communities, because it's not possible to do this voluntarily, because this is a work. This is an example from Brazil that they are scaling up access to HIV pre-exposure prophylaxis through the ministerial resolution that approved the nurses can prescribe PrEP. This is an intervention that they are doing to accelerate the PrEP implementation. In this scoping review, they analyze the different service delivery model for HIV prevention, based on the target population, delivery setting, PrEP provider, and delivery channel. And in these 2 diagrams, you can see the lack of PrEP in reproductive health service. All the majority of the implementation projects are led by a specialized clinic, by nurses, physician, specialist physician, or clinician training, but lack of the community setting and also lack of the reproductive health service. Only one of the studies analyzed include pregnant and postpartum women. This is a lost opportunity because PrEP can be used for the pregnancy woman, for the pregnant woman, sorry, and in the postpartum also. And if you see the target population, the majority target is people are high risk of HIV, not specified. That include MSM, transgender woman, sex female worker, but not other like youth are included. We found only of the implementation studies was direct target to the youth population and one of the people in a serodiscordant relationship. That means that we need to think differently if we want to achieve other type of population. The assignment was, I need to talk about HIV self-testing, PrEP, and partner notification. This is a lot, and I'm trying to give them a few examples of what is happening at the war. And this is a result from Malawi self-testing distributed by the partner increased testing. What is this? Malawi decided to compare HIV self-testing to the partners to the normal testing. And they give them to the positive person 3 HIV self-testing for the partner. And in the other arm, they asking, please tell it your partner came to make the HIV test. What is happening through the HIV self-testing, the primary partner tested was almost 80%. And using the traditional way, they only reach 27%. This is a very clear result with the HIV self-testing using through the partner. Is more feasible to have an HIV test for the partners. This is a lot of the evidence of the articles to talk about HIV self-testing to support PrEP delivery. The WHO recommendation now said you can start PrEP with an HIV self-testing negative, okay? Because HIV self-testing is very specific. If you are negative in the HIV self-test, you are negative. Remember, HIV self-testing is a measure antibodies. Yeah, it's not make diagnosis. It's really do it for discharge the diagnosis of HIV. This is in the policy brief, included also the model for pharmacy self-testing for PrEP delivery. And this experience reduced the clinic visit time by 50% and increased adherence and retention at 6 months. Because the PrEP programs complain about the people start PrEP but not keep it in PrEP. Maybe they came the first month, but during the first 6 months, they give up of the PrEP, and they will come back in 7 months when they have a recent encounter or when they really decide to start PrEP. This is some model that we can adapt to our reality and use PrEP delivery through the pharmacies or through the community settings. This is an example for Central America that include Guatemala, El Salvador, Honduras, Nicaragua, and Panama. This is an example of the partner notification assisted cascade. They make this, for me, beautiful diagram because they have, they work with the index case. They have more than 2,000 people and positive, and these people offer the partner notification assisted. 74% accept the strategy. And they found an average that 1.6 partner for each one. From the contact reached, they achieved 75% of the contact from these 2,000 persons. And from this, 85% was eligible for HIV tests. They make an HIV test for the 89% of the eligible. And they found 17% of HIV diagnosis. And for the diagnosis people, they linkage the 95% of the people. That means the partner notification assistant is a good strategy for finding new diagnoses from HIV. This is the slide that was provided for the implementer of this project. And this is another example of Central America, is El Salvador, that the blue man or the blue person is an HIV diagnosis, the green one is HIV negative, the coffee, the brown, sorry, the brown is HIV in treatment, and the orange is not reached. If you can see from one, this does not have a red light, but you can see the first person on blue. They offered 3 contacts. One of them was positive, 2 negative. This person was positive, give them 6 contacts. And from these 6 contacts, they found 2 positive, 4 negative. These 4 negative will be put in PrEP. And the 2 positive, they found 4 person, another 2 person, and they found another positive. And the chain continued at the end because they make all the analysis. But the interesting is they have different modalities to increase the selection by index case. They can use telephone call notification. They can use dual notification, that is call and also reach through the social network. And also they can arrange a meeting place to talk with the people. This is made from the civil society organization together with the Ministry of Health. This is another example from Colombia. They are using dual HIV syphilis tests for in the community setting, in tents, in the street, in the extramural activities for induced demand. And they are using the dual test. And for example, if they have syphilis positive, HIV not reactive, they put the penicillin in the field, and they complete the algorithm with the not treponemal test, and if they're reactive, they complete the treatment and the follow-up in the clinic because they have one facility and a lot of tents that are in the street. Please let me know when I have 5 minutes, okay? 3 minutes, oh my God. They told me that I have 20 minutes, but okay. This is the example of Guatemala from transgender women. They have a clinic, and they start this clinic 12 years ago, but with the support of Global Fund, they have now 8 mobile clinics through the country, and they cover all they name it the hot red zones, it's the high prevalence from HIV, and they offer a comprehensive care for help to gender identity, change the names, and also address the social determinants of the health. And they have now 800 people in PrEP in 1 year. This is another example from Mexico. This is a clinical for transgender person. They are making also the tramit for gender identity, festival, give them all the information through the QR, all the service they can receive, and also they are using peer groups, the trans men, trans women, and also including the family and the adolescents in this peer navigator. They are using peer navigator to reach the people for putting in PrEP. This is an example, the one demonstration project supported by Interagency Unit Nations, PAHO, UNDP, support the country with a small project that now is a public intervention, start with 500 people. This was pandemic time. And now, at the beginning of 2024, they reach 7,000 people, and they have 13 cities with PrEP. This is something that happened in 2 or 3 years. Now it's a law in Colombia. Now we have cabotegravir injectable from the studies 083 and 084. And I want to show this is another implementation project. The name is PrEP Choices 1519, because it includes young people between 15 and 19 years. It is in 3 cities of Brazil, Salvador, Belo Horizonte, and Sao Paulo. They can choose between the cabotegravir long-acting PrEP and oral PrEP. They use, at the beginning, a chatbot to talk with the young people. This was sustainable because the chatbot was very expensive, but this was a very good experience for linkage the young people to the project. If you can see, they said that they start with oral PrEP. They keep it in oral PrEP by 2 months. After 2 months, the 14% switch to cabotegravir long-acting because they have the opportunity, they have the choice. This is a very successful implementation project. When the young came to the clinic, the process during 2 hours and 45 minutes is supported by peer young navigator, and also the nurse make the consultation and put the injection, and in less of 3 hours, the young person goes with the shot applied. They use different ways to demand generation. They told to the kid, choose the one that fits your rhythm and makes you feel protected, because they can choose event-driven PrEP, daily oral PrEP, or long-acting injectable PrEP. They also use a lot of social network communication developed together with them. And one of the best recommendations that they give us is addressing mental health issues within HIV prevention programs is critical to well-being and effective protection of adolescents. This is the two last slide, promise. This is a lenacapavir injectable. The Purpose 1 trial is published in the New England Journal. This includes 5,345 participants that include adolescent girls and young women. It was effective. Only 0.2 participants discontinued the treatment. They have only 2 infections. And the Purpose 2 include MSM and transgender women and no-binary person. But this is not published yet, but we have some results. They only have two infections during the year of the project. Now it is an open label phase. But you need to know cabotegravir is intramuscular, and the gluteus or the leg. But lenacapavir is subcutaneous in the abdomen, 1.5 milliliters, 2 shots and the first visit, 2 shots and the second visit 28 weeks later. And you need an oral loading dose that include 4 tablets of 300 milligrams each before they start the injection. The day that injection, you need to use the oral load. And for this presentation, I want to enhance the message that we need to rethink the post-exposure prophylaxis. It's a tool that we have a lot of decades before. It's effective. It prevents HIV more than 99% of the cases. People know that PEP is effective, and in the new WHO recommendation, they said we need to give them access to PEP in community settings. We need to put the antiretroviral therapy in the first level of care, and we also think about the use of self-administered tests to guide the use of PrEP. You can make a combination from HIV self-test. It is negative, the person who can start PEP. And one example is Canadian. Canadians are doing this type of analysis to go into PEP, to PrEP, to enhance the adherence to the program. They name it the PrEP in Pocket. They give them one cycle of PEP to PrEP users for in case of they have a sexual encounter without using PrEP. For finalize, we need to know no single prevention intervention can impact the numbers. When we are talking about innovation, that means new ways to do the things for reach the target. And we need to be very clear what is our target. There is a need to work on oral PrEP expansion and demand generation. There are a lot of things that we are not doing. We have the tool for end HIV and AIDS. We need to shift paradigms. The person-centered approach mandates the expansion of PrEP and PEP and antiretroviral options. Increased access to service requires differentiated approaches, including task sharing. Paradigm shifts are challenging and require political will, multi-sectoral work, and innovation. We need a strong commitment from the government and civil society to achieve the end of the HIV and AIDS. Thank you very much.